Welcome to Channel 17, the Town of Colonie Government Channel.
All right, everyone, thanks for coming. Really appreciate it. We usually do a new book, or a fairly new book. This book's been out for, I think, over a year, but it's hard to get a hold of a doctor, as we all know. But Dr. Graney was here minding her own business. She was at the mother-daughter book group with her daughter, and when she came out, I said, would you want to come and talk about a book? And she said, sure. So it was easier than I thought. But she's over at Shaker Pediatrics, and I'll introduce you with the words of her father-in-law, John Graney. You guys might know him from the radio, but I said to John, before we went back to Florida, I said, John, I met your daughter-in-law. She's coming in February to talk about a book. And John goes, Sheela? Doesn't get any better than her. So we should all have a father-in-law like that. So here's Dr. Sheela Graney to tell us about the book, How Doctors Think.
Thank you all for coming. I told Joe I'd like to read, so I read a lot of books. Mainly, I like to read fiction. So, on my days off there, and I read a lot of journal kind of work for my, can you hear? No? Better? So I read a lot of journals for my practice, but I really can't say that I read a lot of books about medical issues outside of practice. So, I thought like a novel, it would take me a day or two to read this book, and then I would come up with my talk. It turns out it took me a lot longer to read this book. It's not a quick read, and it is something that you really have to think about. So I don't know if anyone got a chance. Has anyone read How Doctors Think? So a few of you, and that's wonderful. So you can definitely let me know if you kind of got the same feeling from it that I got. So I'm coming from a little different perspective as a physician. He really didn't write this book for physicians. It's written for patients. So kind of the premise, I think Dr. Groopman was trying to give the reader an idea of what goes on in a doctor's mind when he or she is treating patients. And he breaks it down into little sections. So he looks at a lot of different specialties in medicine, and so I thought he did a very good job of looking at a multitude of specialties and coming up with different ways that different kinds of physicians will think. So that's the question. So how do doctors think? Are there definable reasons why doctors make errors in their thinking and their judgment when they're coming up with diagnosis and treatment strategies? So, and kind of what are the pitfalls? What are the things that your physician may do that would lead them to make make judgment errors? So, in the big one, I think for all of us, and I think we all feel it now, is time, right? So when you walk into a physician's office anymore, you don't think you're going to get an hour with a physician. You know that they have 10 minutes allotted to you. And so, you're trained in medical school to think in these logical, complaint, get a full history, do a very comprehensive physical exam, take your time, think about a whole list of possible diagnoses, and then come up with your treatment plan, okay? So, so that's how we're all trained, how it starts out. But then, what he points out is that that's not really how you practice medicine, right? So we come up with these quicker ways, right? Strategies for thinking about things faster because we have to. And because for a lot of times, it really is how you're going to save someone's life. You can't have an hour to think about the person that's lying on the ground. You have to quickly come up with what's wrong and come up with a plan of how to treat them so that you can hopefully save their life. And so you want your physician to be that. You want them to be at that height of anxiety where they can make quick judgments and be in the position to come up with the answer. So that kind of follows through, and he calls that heuristics. Heuristics is the term used to make snap judgments, quick things. So thinking that that's how your doctor is kind of coming at you when they see you in their office, his feeling is that if physicians and patients are aware of this way of thinking, and I hadn't really thought about it, then maybe some of those mistakes in judgment can be avoided or at least corrected more quickly. So he looks at 3 common errors in the physician thinking process. The first one is anchoring. So if you seize onto an initial complaint and then form a snap judgment, so you immediately, kind of thinking in your head about what the answer is. And then an attribution error, so looking at the patient and forming a stereotype about them. So the healthy runner versus the known smoker versus the known obese patient, right? So you may think about these patients differently just because you look at them and form a quick judgment. And then availability error. So what's going on in your community? So what are you seeing in the area and what that complaint fits most likely with, right? So you come in with a cough and the first thing you're thinking about is a cold, maybe. So, and just to give you an example even from my own practice, and these are ways that you can make errors. So I had a child come into my office, a 5-year-old male who was otherwise healthy, had a little runny nose, no fever, and the main complaint was that he had a cough. So I know this going into the room, and nurse has already seen them and given me these complaints. And then I see them, and it's only been going on for a few days. Mom had noticed it. They'd noticed it a little bit in school, but it was kind of a barky cough. So I listen, and he's got stridor. So stridor, and that means that sound that he makes. And it's a common complaint. I see this a lot. So my initial diagnosis from my physical and from the history was croup. So there's croup in the community. So that sounds like that should be it. So I send them on their way. I tell them what to do with steam treatments, and a few days, your child should be better. And then 5 days later, he's back in my office, and now he sounds a little different. I'm a little worried, so I get a chest x-ray. And this kid has a huge mass in his chest. And that's the reason he's got stridor, not because he's got croup. So I made all of those errors in my judgment, right? He had a barky cough, so I was probably thinking croup before I walked in the room. He was this healthy 5-year-old. He'd been here for his physical 2 months before. He's growing on a perfect curve. He has no fever, and he's not complaining of anything. So I'm not thinking there's anything seriously wrong with this child when he comes in. And then availability, okay? It's November. I am seeing lots of croup in my office, so it's easy to come up with that judgment because that's what's around. So fortunately, I did tell them that. It should only last a couple days. They should be feeling better. If they're not better, come back and see me again. And by this point, his exam had changed just a little bit, but I was concerned enough, and he should have gotten better, that I got the test that could figure out what was wrong. So it all turned out well. So getting back to the book. So who should read this book? His target audience is the patient, and I definitely think that patients will benefit from it if you can get through it. It's a long book. So you can really think about it that way as almost a reference book. So if you know the kind of doctor you're going to see, you can read that chapter because it is really broken down into little essays. And then for physicians, is it a book worth reading? I do think it is, and again, because even for a little while, just to think about that made me go into my office and look at patients a little bit differently. So to try and think about my biases. So what was I thinking about that patient when they walked in the room just because of how they looked? And definitely that happens. And especially after you've been in practice for a while, it's easy to do that, to be thinking about quickly getting the answer and sending them on their way. So, what he came up with were critical questions for your doctor, right? So So things that you can be thinking about if you go into your doctor's office and they come up with a judgment or a decision about what's going on with you in a treatment plan that maybe you're not quite sure they're right. Or how can you make sure that your doctor's really thought about what he's said to you, or she? And really, they were easy things, but just to ask your own physician when they tell you an answer, what else could it be? So that would make your doctor think more, come up with their differential, give you that list of 10 things that are the possibilities when you go into their office. Could two things be going on to explain my problem? So they have to break it down more closely, look at each symptom and explain to you what's going on. Or is there anything in my history or my physical or my lab work that's at odds with what your diagnosis is? So those are the kind of things that he's trying to give patients as little armor to go into your physician's office, or again, maybe not when you're going in and with a cold and you're better in a week, but if you have something that's going on and lasting, that you can go in now and tell your physician to help them better think about your problem. And so I'll show you how the book is organized. So the first thing he talks about is residency. Then he talks about kind of learning from our errors, how physicians over time, just like that case with this child with leukemia and that mass, definitely makes me think differently about a kid that comes in with a cough. And then he goes into each little specialty: emergency medicine, primary care, hospital-based care, the specialist, the surgeon, the radiologist, the influence of drug representatives and on our practice, and care of the terminally ill. So again, it's a book that you can read just one section if that's something that's geared towards you. So I think it can be helpful. And then I thought that for the rest of this, I would just concentrate on what I know. So I'm a primary care physician. I see only children from the ages of newborn all the way through the age of 21. And I work in a private practice with 5 other physicians, 5 total physicians and a nurse practitioner. We probably average 25 patient visits per day per physician, and over a course of a 10-hour day. And so it's a lot of juggling. And what his chapter on this, he titled it "The Gatekeeper." And so he said, why are primary physicians labeled as gatekeepers? And we think about that now, that it's become, for insurance companies, a stopgate, right? So we're supposed to make sure that you only go see a specialist if you really need to see a specialist. Or that's what the insurance companies told me, that's my job, right? So I did not train thinking that was what I was going to do, right? I thought I was going to treat patients and use my specialists, and not use them, but they were my colleagues. They were the people that trained me. And so it was never an effort of keeping anyone away from them, but using their knowledge to help treat my patients better. So, and I think that for most primary care physicians, that's the way they think about themselves. I can tell you that I have never limited access to a specialist because I had to write a little, referral note. So I've never had a patient come in and tell me, I really want to see the specialist, and said to them, you can't see them. Yes, this is something that you can't do because there's no reason for you to go. I might talk to them about what their problem is and help them and make sure that they were going in the right direction, and maybe redirect, but I've never been, and I don't think anyone in my office has ever said, you can't go. So I don't think it works, so it doesn't work. We can't be gatekeepers. And then I had to think about what I really think I do. And what I always thought as a pediatrician was that my job was, out of the hundreds of healthy kids that come into my office, my job is to find the sick one, right? So every day I have to think about who is really sick and who is not sick, and I have to make sure that they are treated the right way. And I like that part of my job. Then the other part is to support parents and help them to thrive and to promote wellness. And so I'm going to read a little quote from the book about what actually it's a quote that he took from a pediatrician and what she felt was going on in primary care now. So it's called Doctors of Steel, and it puts us in the perspective of superhuman superheroes. So, docs of steel, faster than a speeding bullet, yet with no stone left unturned. Paperwork, bring it on. As we draw our capes around us and prepare to plunge into the next pit of human suffering, we pause only to check our schedules, to ensure that productivity remains on target, juggling BlackBerries, cell phones, electronic medical records, note from specialists, lab results, patient phone calls, referrals, radiology requests, beepers, handheld formularies, patient satisfaction surveys, color-coded preferred drug charts from insurers, and quality report cards from HMOs. We forge on as our patients wait, shivering expectantly. The superhuman demands of our specialty have either morphed us into steely-eyed combatants or reduced us into blithering, overwhelmed, white-coated globs of jelly. We now practice triage medicine and surrendering our time-honored bedside roles to hospitalists, slicing FaceTime with patients, and retreating to administrative roles, appending MBA, Esquire, or MPH to our names to shield us from the line of fire. So, again, I was a little taken aback by the whole article on primary care because I haven't thought about it as being this severe. I still enjoy my job. I like seeing patients. I enjoy the time that I spend with them. There is pressure. There is pressure for time spent with patients. But again, I thought that was my one criticism of the article. You kind of came away thinking that primary care was going to die out because no one was going to do it anymore. So again, just looking at ways that you can help your physician to treat you better, and to look at all the specialties. Again, there's a chapter in there about every specialty and how they can better serve you. And that is my talk. Does anyone have questions about the book, about practice?
I have a question. How much of your practices are you influenced by threats of litigation from lawyers out there? I mean, if you say in your own mind, I should give this person 3 tests, and because of lawyers, you're going to give them 10 tests. That's what drives up the cost of medical care.
Sure. Yeah, I try to think that I'm not, but I'm sure that there is in the back of my mind, that there's thoughts that I think with children, you have a little bit more leeway because it's rare that a parent wants to put a kid through a procedure or a test if they really don't have to. And so if I can convince them that they don't need the test, then I'm usually able to do that with parents. But I feel more pressure from insurance companies, I think, than I do from lawyers. Pressure to not do tests, pressure to not do maybe what I think would be a full, complete workup because the cost, and cost is a big factor. I mean, cost is a big factor in what we do. But I think that they're the ones I fight with more than lawyers.
How are the perks with the pharmaceutical companies in your office? You get big trips and...
Yeah, well, I'm a pediatrician, so we don't use that many drugs, I mean, that's the thing. I mean, if you think about pediatric practice, I use, 10 generic antibiotics and, a couple of maybe 1 drug out of every 20 is still brand for us. So we're not really, we're not a big target for insurance for the drug representatives, and we limit our access. So in our office, we don't do lunches with drug reps. We go out to lunch ourselves, separate from any influence. And We really only set certain times when they can come into our office, and we don't let them in our drug closet. Because it's like a, and again, I understand, and there's really good reasons why we need to know what drugs are out there. So it's definitely, there are times when I ask them to come in because they have a new drug and I need to know about it. And the other part of that is that patients know about drugs sometimes before I do because they're seeing them on commercials now, right? So, I mean, I can't tell you how many teenagers come into my office and tell me they have social anxiety disorder. So, because there's been a Zoloft commercial and they saw it and they come in and they tell me, I need that medicine, I have that. But what teenager is not anxious exactly in school, or has peer pressure? So, you can really fight those things, and those are the issues I have with drug companies. Is that, and then that's a big part of what he talks about in that article, in the essay on drug companies, is they can even almost make up disorders, right? So they've made aging a disorder, right? So we should all be on estrogen and we should all take testosterone because that will keep us from getting older. So, those are things that you have to fight, and you have to be thinking about as a physician, because there's 10 articles in, just mainstay magazines geared towards males and females, telling them that they have a problem and that it should be addressed with some kind of medication.
Wouldn't your medical journals have their medicines, the recent medicines, and their use without having to depend on a drug company?
Well, I mean, you do. You do have some information, and usually, most of my information is coming from that. Is coming from a physician that's talking to me about, new practice, and I think the hard thing though is, again, if you're seeing 30 patients a day, for some things, it's a lot easier to have someone come in and give you the articles, and you can read them yourself and talk to you about the drug. And again, it's just a starting point, but especially if I've already had 10 patients come in and ask me about it because they've seen it on TV. So it might just be something I haven't quite gotten to. And so you're right. Again, there is usually medical information about these drugs, but it's hard to tease out. Because you're looking at, I have a stack of magazines this high on my desk that that I periodically go through and throw out the ones that I've read, and sometimes the ones I haven't read because I've got a new stack that I have to read now.
That boy, the 5-year-old, does that make you think twice about? Obviously, you can't ask for a chest X-ray for every cough or runny nose that comes through your door. How do you balance that, or do you feel you diagnosed that correctly by waiting 5 days? Right.
Well, yeah. I mean, if you go back to that case, I did do a few things. So that was the what saved me, because it could be that this kid doesn't come back to me for a month, and that tumor's gotten so big that it's blocked off his airway and he dies. So. Sure, that was very serious what was going on with that child, and he really had only had symptoms for a week before he came in. So they left with a handout on croups. They left with medical information about the duration of illness. So I didn't leave them saying, this could go on for a month and you don't have to worry about it. They knew when they left my office that if this kid wasn't better in 3-4 days, that I wanted to see him back again. And then at that point, when they came back again, I could have sent him out again, or I could have maybe treated him for croup. I could have put him on steroids, a medicine that would help with croup. But I did take it more seriously this time because it didn't make sense to me anymore. So now it's not croup because it can't last for a week. That doesn't happen with that illness. So I had to think about those other things. And really, when I listened, he sounded like he had a foreign body. So I thought this was a kid, when I sent him for the chest X-ray, that maybe swallowed a quarter or some kind of something. But I knew something was obstructing his airway. And again, the test to do is that, and that was something that was drilled into my head as a resident. You never put a kid on steroids if you don't know what the cause is, because it could be something like this. And if I would have put him on steroids, it would have ruined the diagnosis. It would have made it very difficult to figure out what was going on with him, and it could have put that kid into really desperate he could have really gotten sick quickly. So again, I did not really mistreat him, but again, I think that you can see how easy it is for a physician to make those errors if they're just thinking about what's around and what's. So no, I don't think it was wrong for me to not get the x-ray the first time. And the family wasn't mad at me for not doing that. What I'm glad I did was I didn't treat him the second time without getting the chest x-ray, because that would have been wrong. And then, they would have been angry. They would have been upset with my treatment, and I would have been upset with my judgment.
Yeah, the Obama administration is going to propose some changes in health care. We don't want it to be like Canada and some of those other places, but what are your thoughts on that?
Well, I think that we have to make changes. I really think that some of these things are true. The issues with primary care and access to care is it's going to get squeezed. Because, I thought about this afterwards, is that, I started out full time. I worked for, the first 6-7 years of practice full time in my office with 2 children at home and, and a husband that also works. And that is the majority of primary care physicians, really, or all of us, right? Two income households with families, and seeing 30 patients a day, and going home with 10 charts and worrying about what's wrong with that few that are sick every single day takes a toll. And I only work 3 days a week now. And so again, you look at where you're training physicians, but if they can't even keep up. And I was in a program to foster primary care. I was in the Siena Albany Med program for humanities and medicine. I was, I have a minor in sociology and philosophy. And the goal was to promote physicians to go into primary care, to take over the caring portion of that medical role, and not to go into a specialty. And again, because that's what everyone was doing, right? So, so I don't know how you feel about it, but I say when I transfer a patient from pediatric practice to internal medicine, it takes 6 months often to get you in for a physical, right? And it takes 2 weeks to get in to see an internist for a sick call. So, and the reason that that's happening is that there's really no emphasis on that as being important in the medical community. So, so I hope that they look at it and they look for ways to get better access to care for everyone. And it's going to have to come down, right? So costs are going to have to come down for some of these specialty care programs. And so that has to be where the emphasis is on providing that for everyone.
Have you gone to electronic record keeping in your office?
We have. It was horrible, but we did it.
Are you in agreement with the political view that this is going to solve a lot of problems?
No, it's not going to solve any problem. Well, it's not going to solve time. It's not faster. No. So it's not going to make doctors have more access and more time because they're doing this. There are some really good things about it. Again, as from a medical legal standpoint, the documentation is tremendously better. So I have much better, and I love the access that I have to patient charts. So I can sit at my desk, I'm not running back and forth, even from my home. I can actually look at your records. So I have it in front of me when I'm treating you. There's going to be less errors in medications because the scripts get printed right off of my computer and sent right to the computer at your pharmacy. So those are great things that are coming from this system. But and it may be a great thing, right? That I can give you a DVD or a CD-ROM that goes with all of your medical records on it, and you can take that with you to the specialist instead of that big stack of papers. And so I think things are not going to get lost as easily. There's definitely going to be a lot easier populating of lab work into your system. I can pull things up much quicker than I could before. I'm not scrambling through a stack of papers this big, and that's your chart. So there are going to be really good things about it. I think that it is the way to go, but I don't think it's going to make things faster or more efficient.
You have an excellent, as somebody who has a 20-year-old who developed a peanut allergy, do you have an idea why peanut allergies become so prevalent?
I mean, again, it is a. I don't have a great answer for you.
Yeah.
I think that there is definitely something to do with our immune system, and it may be, part of it is that factor of what we're bombarded with every day is becoming overloading to our bodies, and so I think that you have to look at pollution and preservatives and all of these things that we're kind of exposed to that may be toxic and irritating our system and making us more sensitive.
And also people who have severe allergies are living long enough to reproduce.
True, but you know what, I think that you're seeing it a lot in patients, and that is, we were thinking that, right? So these highly allergic families are the ones that are going to develop peanut allergy. But the really scary thing is that it's not. So I'm seeing families that have no history of allergy at all, and these kids have peanut allergy. Life-threatening, anaphylaxis.
Oh, yeah.
And there's no family history at all. So, again, I think that we look at all of these things that are becoming the big medical issues in children, autism and increased allergy and asthma, and I think that there's going to be some kind of common thread with those, and it has to do something with our immune system and what we're doing. So I don't have an answer, but.
Isn't it that they're also exposed to the hormones that they give and antibiotics they give to the cows, that the kids grow up with that in their body?
Yeah, I know. I mean, that was, okay, so my mother, who's here, I had 2 kids. Yes. She reads a lot of pretty liberal magazines, and she called me one day and said, "You have to stop giving your kids milk." And I thought, well, I can't do that. So, but she said, do you look at those? Look into it, the hormones and stuff and the antibiotics that they're giving to the cows, and why can't they do that in Canada and Great Britain, right? So these countries ban that; they wouldn't allow that. And then I looked, and I honestly could tell you, I could not find a single study that was ever done that showed that it was okay. So I did get worried about that. I mean, every drug that is ever given to anybody has to be studied for 30 years almost before we allow it to be given in this country. But if it's a food product, it doesn't have to be tested. So, so again, the backlash is that now you can find it. So at that point, I'm spending $4 for a half gallon of organic milk, right? In kids that were drinking 2 gallons of milk a day, a week. So, so that's very unaffordable to most families, right? If you look now, and again, I don't know if you look on the Price Chopper container now, they say no artificial hormones are given and no antibiotic products. So, so there has been a backlash in this country, and they seem to be responding, but I will tell you it is scary that is the truth. You don't have to test it if it's a food.
What is your take on the role of midwives and home births?
That's a hard one. I, as a physician, would have a very difficult time promoting that because I see the scary things that happen, and I really can't imagine myself being at home with my first child, who I went through 36 hours of labor with and ended up with a C-section. And it was scary. It's a scary thought. So I can't say that I would do it myself. So
Well, I'll tell my daughter that.
Sorry. So, but that
was home birth.
You what?
I do have a grandson who was.
Who was a home birth.
Home birth.
Yeah, and I get it.
And
he's doing very well. And I think that the majority, 90% of the time, you are going to see that nothing goes wrong, and it's a great experience. So. You're better off, right? And that's the thing. So, so again, it just comes from my training, and again, seeing the bad things, the bad outcomes, And I have a couple of bad home birth kids in my practice. So, so again, that definitely biases me.
No more questions? Well, thank you, Dr. Graney, for coming by. We appreciate it.